Good evening. This is Dr. McDaniel at GYN Corner. Today's Monday, May 6th, and I'm continuing on the presentation of urinary tract infection, or UTI. As I stated over the weekend, a UTI is defined as greater than 100,000 colony counts on a bacterial culture. And symptom and sign-wise, the usual things that people will experience or will complain of or will note are urgency, waking up at urgency, which is feeling like the bladder's full, and when you go to urinate it's not actually full. Nocturia, which is waking up at night to urinate and either you usually don't or it's more than you usually do. Urinating more frequently than usual, any kind of pain, pressure, discomfort, burning or unusual sensation when you go to urinate or as soon as you finish urinating, that's dysuria. Blood in the urine or noticed on the toilet paper, that's hematuria. Lower back pain or abdominal pressure discomfort even when you're not urinating. Urine having a bad odor. Urine being concentrated. Nausea, vomiting, or fever, chills, which are all four of those are signs of an infection that's ascending from the bladder, which is a cystitis, into the kidneys, which is a pyelonephritis. And the sensation that when you start to urinate, the urine doesn't flow as soon as you want it to. There's a bit of a pause. That's called hesitancy. And or the sensation that when you finish urinating, there's still urine in the bladder, it's not completely emptying, or the feeling that you have to bear down to try to get the last bits of the urine out. That's called urinary retention. So those are all the usual signs and symptoms of a urinary tract infection, which can be anywhere from the bladder to the ureters through the kidney. I stated yesterday that I would mention the treatment. So we always send the urine for culture. That's the gold standard to confirm that your symptoms really are due to a bacterial infection of the urinary tract, which is causing the signs and symptoms which are due to the inflammation. You can do a urinalysis, which is just a dip. A lot of people think that the urinalysis is necessary to diagnose and to treat bladder infection, cystitis, or UTI. That's not the case. A lot of clinics or urgent care centers will do a urinalysis. They'll dip it to see if there's evidence of an infection in the urine. So looking for nitrates and looking for leukocyte esterase. The catch is that if there's contaminant from the skin or contaminant from vaginal discharge, those are going to be present anyways, so it's not super helpful. And they're looking for bacteria also, but that's also from a contaminant, so it's not super helpful to do the urinalysis. I tell patients based on the symptom, that's going to be stronger. So based on their symptoms, if they have at least two of those myriad of symptoms, I'll write them for the antibiotic, and then we send the cultures to confirm or to refute that the antibiotic was the appropriate choice. The urinalysis can also pick up blood, but again, that can be a contaminant. So the urinalysis is a nice adjunct for some people who potentially maybe aren't comfortable just writing the antibiotics based on the symptoms, but it's not really. So the signs and symptoms or the patient history is going to be the more important. If a kidney infection is suspected, so someone has nausea and vomiting, especially if they have fever and chills, you do an exam to see if they have what we call costovertebral angle tenderness. So if I pat their back, the upper back, not the lower back, because the lower back is the nerves from the bladder go to the lower back. So if I pat their upper back where their kidneys are located, or if I jar them and they have exquisite or excruciating pain in that upper back area, that's a sign of kidney inflammation due to infection. So the usual antibiotics that we write for the bladder may or may not be strong enough or adequate to treat the kidney. And the other catch is if they have nausea, vomiting, they may not be able to tolerate antibiotics in order to get the treatment initiated and to clear the kidney infection. So oftentimes we will write an antibiotic even if someone has that back tenderness, but I tell patients if they're vomiting or if they're not significantly better within 24 hours, so their fever's gone, the chills are gone, the nausea and the vomiting is gone, or at least the back pain is gone with the fever and chills. If they're not significantly better within 24 hours, they'll need IV antibiotics for a couple of doses to quell the initial kidney infection, and then they can continue with the pills. The treatment is always going to be antibiotics, and the Centers for Disease Control, the CDC, has been sending out notifications and notices for at least 3 years now not to write ciprofloxacin or Cipro for uncomplicated community. That's because ciprofloxacin is a broad spectrum antibiotic, and trying to pinpoint the treatment for antibiotics when we write for the pills. We're trying to be as specific as possible. If we continue to write the broad spectrum or the ciprofloxacin to treat a bladder infection that could respond to something that's more specific, we're going to start seeing resistances to Cipro, and we're not going to have very many options once bacteria are resistant to Cipro. So ideally, we like to write for, or should be treating for, as narrow of a spectrum as possible for the bladder, because most community-acquired run-of-the-mill garden variety bladder infections or cystitis, UTIs will respond to the usual treatments. So most women, and I assume men also, but I don't deal with men, I'm a gynecologist, so most people will respond to macrobid, nitrofurantoin, augmentin, Bactrim, trimethoprim, sulfamethoxazole. Those are the usual myriad, or the usual collection, or as I like to say, the usual suspects to treat a bladder infection, cystitis, UTI. It's uncomplicated. Now, prevention of a bladder infection or a cystitis is relatively easy. If you drink lots of fluids, and as I like to tell people, a good gauge is that your urine is as clear as water or almost looks like water within 1 to 2 hours of awakening, and you maintain that. If you drink lots of fluids, you will keep the kidneys, the ureter, and the bladder flushed so that bacteria won't have a chance to build up and to ascend. And then if you don't hold your urine, if you urinate when your body tells you have to go, then you're going to keep the urethra flushed. And everyone gets bacteria that climbs into the urethra throughout the day. If it just sits there because you're not well hydrated, or you're holding onto your urine, you're not urinating frequently, it will have a chance to ascend into the bladder. If it ascends into the bladder, it will have an opportunity to build up as an infection, and in that case will potentially ascend into the kidneys. So if you drink lots of fluids, you stay well hydrated, you don't hold your urine, you urinate as soon as your body tells you need to urinate, then you should not get a bladder infection if everything is normal. If you hold onto your urine, you don't drink lots of fluids, you stay dehydrated, or any kind of activity that increases the potential for bacteria to get into the urethra. So tight jeans, thong underwear, intercourse, exercise cycle, or regular bicycling, anything that puts friction and increases friction in the genital area will increase bacteria into the urethra and allow for it to potentially turn into an infection. I'm going to stop there because I'm trying to keep the presentation slow. I'll finish up tomorrow by just giving some additional information on prevention and homeopathic management and treatment of cystitis, bladder infections, UTIs. So this is Dr. McDaniel at GYN Corner here in Midtown Manhattan. If anyone's in the area, they're welcome to come by. I have also been placing these not just on the Facebook, but also on YouTube, GYN Corner on YouTube. If someone wants to identify a specific presentation, it's easy to just, they're logged there on YouTube. I already know, like, the video and audio and all, and audio and visual, all that presentation's not up to par as the YouTubers, because I'm really not a YouTuber. I just am placing these to start to try trying to get information out to help people who perhaps aren't getting a lot of information from their own physicians, and the Google searches are difficult, or who aren't coming in, so to provide a resource for information. There aren't a lot of resources that are reliable. So hope this has been a helpful presentation. And if you have questions, or if you have topics you'd like for me to address, please send questions either through here, the Facebook, or through the YouTube presentations. Thank you again for watching. Have a good night.